What's up, Dominic and Jordan? Can you guys hear me okay? Hi, Maddie. Hi, Caitlin. Hi, Dan. Hi, Kristen. Jordy and Dominic are with us too. Heather's with us. Heather's in the house. Sean, what's up? Thank you for coming. What's up, Logan? How's everyone doing with this corona? Meeps is here. What's up, James? How's everyone doing with corona quarantine combo? Everyone handling just well, or is everyone's about to lose their mind? What's up, Ron? RH, everyone, is Ron with us. Wayne Quattrone, what's up, brother? So, as you may already know, that there is a natural delay that happens with these equipment that we have over here uh, between the speed of the internet, so on and so forth, and the OBS Streamlab that I'm using. So it creates a little bit of a delay. So if I don't answer you right away, just realize um, okay, we got a warning here from YouTube. Says not receiving enough video to maintain smooth streaming. I wonder where that's coming from. It's not glitching on your end, right, guys? No, I want to log into my own channel and listen to how this is going on. Just see what you guys are seeing. let's try this. Check mic 1. So I just canceled the audio input capture just to see if we can have better sound. Seems like a minute 30, the average delay, which is not bad. CNN is about 30 seconds. Hi, Kiara. Perfect. We got rid of the echo for now. Sean, thank you for joining us. Pam, thank you. How's everyone doing with the shortage on hand sanitizer? I went and got a 5-gallon pail made locally of hand sanitizer. Obviously, um, you can't ask people to dip their hand in the 5-gallon pail. So I went and purchased all the traveling size shampoo and conditioner bottles from Walmart. Got about 9 packages. They had 4 bottles each, and set up sterile formulation environment and refilled those from the 5-gallon pail just so people can have enough, small bottles to take with them home, because you can't afford to get a provider sick. You get one person sick and they didn't know it, you shut down an entire department for about 14 days. Nobody can afford that. So anybody have questions from the last lecture? Anything you want me to go over? Hmm. I don't know if the poor signal from his end or from my end, but if any of you getting bounced off, let me know. We can reconnect the stream. So Ron, if you can ask that student if he's accessing the lecture via laptop or a cell phone. I can reduce the resolution for the stream. Let's see if that's gonna help matters. All right, so this is just up. Um, okay, I can try to speak louder. I can increase my voice. How is this sound? Is this better? So let's add filters. Sweet. Yeah, this just in. 170 FDNY members have a coronavirus, commissioner said. So there's 170 firefighters caught it up in New York City. All right, 6:31. Let's get going with our lecture. If my video become distracting to you, I can turn off my webcam so you can focus on the slide. If it gets in the way, just shoot me a message. It's going to take about a minute and a half to come to my screen so I can do anything about it. Please be patient with us. Thank you all for attending this lecture. It's very unorthodox to teach this way. Um, I don't know, Ron probably still here. Have we ever done anything like that in the history of teaching EMS in the county? Since Ron is the god of EMS, or the godfather of EMS, I should say. Okay, so we're going to be getting going with this lecture. First chapter, we're going to be talking about pharmacology. Anything else that pops up to anything else that's going to pop up that you have a question about, let me know. Um, yes, Rob, this will save into the channel. I'm gonna try to keep it up for as much as possible so people can log in later on and review it. If they have questions, they can still shoot me a message either through the classroom or through the YouTube channel mailbox. Then we can take care of that later on. If you shoot me a message and I don't pay attention to it right away, I apologize. Like I said, latency seems to be like a technological problem. It's not gonna go away. We don't have $1 million equipment, but we're making things happen. But okay, we're going to be talking about medications EMTs can administer, general information about the medications. Medications patients can often take, and assisting patient with in IV therapy. So okay, medications EMTs can administer. Yes, right. This will be recorded. It will last for a little bit, but I am not gonna keep it up like forever as like a main video on this channel. We're just gonna keep people, uh, give them the chance where they can come back and look at it. So, what medications can we administer? I just added this fifth line. We can administer aspirin, oral glucose, oxygen, activated charcoal, and Narcan. So the activated charcoal part is something that gone by the wayside a while back. When we started the beginning of my career 10 years ago, um, this was a thing, and it was an item that we have to carry on our ambulance. Activated charcoal, obviously, for ingested poisons. It's a nasty charcoal, very fine charcoal syrup that you have to feed to the patient and prevent them from throwing it back up. It makes their teeth black. Um, Everything. It's nasty tasting. It tastes exactly like what it sounds like. Activated charcoal is non-flavored, so it's job to bind with certain elements of the toxins that patients will be might have ingested that cause the poisoning. But the aspirin, oral glucose, and oxygen and Narcan lately, I don't see those going away anytime soon. Went too far. Let's get back. So chewable aspirin, the job of the aspirin that we're giving it, we don't give it for headaches, we don't give it for fevers. The purpose of the aspirin solely is to prevent clots during like patient having chest pain, episode of chest pain, and then we're going to be assuming that there could be a clot or thrombus of some kind in the coronary arteries that's causing the chest pain and increasing cardiac demand on oxygen. What we're trying to do prevent that. It's like almost like an accident on a roadway where there is a narrowing in the traffic, which is called collateral circulation. What we do, we don't want that to turn into a pileup that will shut down the 90%. So if this pileup will end up occluding the blood flow, cardiac muscle will die very, very rapidly, and the death in these cells cascades about 6 million cells a minute. So we definitely don't want to get there. We don't want the patient to get there. And that's the purpose of the aspirin. Aspirin given in a baby aspirin format is chewable, never adult aspirin. It's normally pink and tastes somewhat alright. Um, I've had it before, not for chest pain purposes, but for headaches and so on and so forth. And it prevents plates from building up and becoming a massive problem, like a concrete block. And so the second medicine that we're going to be giving, which is also an oral medicine, I just want to get back a second for the aspirin. It's an 81 milligram pills, and we give 4 of them to the patient. And we have the patient chew them. This is something the patient does not have to swallow. They need to chew it to turn it into fine particle to increase absorption into the bloodstream. Oral glucose, basically anybody who's experiencing hypoglycemia. Hypo rhymes with low, and glycemia. Glyce is sugar from the Latin word glyce, and glycemia, which means the symptom. So hypo, low blood sugar episode. So basically, these come in 25-gram tubes, 25 gram of glucose within the tube. So we give that also to the patient. Patient have to be conscious and alert and can follow commands. Okay, the one contraindication that the patient is unresponsive and unable to maintain airway. So be careful. Do not just start squeezing these tubes in the mouth of somebody who is unresponsive. You're going to cause a choking victim, and that's considered practice and outside scope of practice. So don't do that. You'll get in big trouble. So patients have to be alert. They have to be able to talk to you, and most hypoglycemics that I've seen, if they're not super critical, they're able to follow command and they can actually uh, work with you. Basically, you're going to see the patient pale, pasty, tired, lethargic, and it's a very common problem. It's not their fault per se. Um, how many of you have left the house and forgot your keys and had to go back and get your keys or your cell phone or your wallet? And so those people, they do this on a routine basis. And most of those people are insulin diabetics. So diabetic on an insulin is more susceptible to get into this situation where they will end up shooting insulin, and they sit on the couch waiting for their meal to get done out of the oven, out of the microwave, and by that time they're tired, they fell asleep, and now they're in trouble because they won't be able to wake up, and the insulin will just like somebody just loaded all the coal in the in a locomotive engine compartment, and boom, now it's running downhill. It's rapidly increasing. That will cause the patient to have some serious issues. Most of these issues we end up remedying and fixing in the field, but it's very, very difficult to get caught up at that point. Sometimes some of those patients have really difficult IVs, but the purpose of the oral glucose is to catch that patient, okay, before they end up into the unresponsiveness stage. So normally the call would come in as weak lethargic possible diabetic emergency. Most diabetics, they know what it feels like, unless it's their very first time, they know what it feels like to lose all their sugar supply in their system after they shot up insulin. They normally figure it out. My father, God bless his soul, he was one of those people that shoots insulin and go puts a meal on the stove, then he falls asleep, and now he's borderlining unresponsiveness. He could barely walk to ask for food or to wake somebody up to help him. But those diabetics are hardened diabetics. They know what it feels like and they know what the fix is. And the longer they stay there, just you got to remember, you can't have a transient, uh, which is a symptom that shows up transient, shows up, goes away. You can't just have a transient hypoglycemia. Hypoglycemia is a vehicle ran out of gas. All right. So once you run out of gas, you're not going to be able to start up again. You can't go to somebody and they say, "Oh, I was unresponsiveness. I don't know. Maybe my sugar dropped." Well, if you didn't eat anything, your sugar doesn't come back on its own unless somebody fed you. So that may not likely be the cause of their syncopal episode. Hypoglycemia unresponsive continues to be unresponsive, really lower, like higher grades of hypoglycemia, very critical stages of it. So oral glucose, no matter what they flavor this oral glucose with, it's always gonna be terrible, nasty, nasty, terrible. I'm just gonna move this mic closer. I find myself sitting off to the side of the screen. So this is one of these issues that we end up facing in the field. So hypoglycemia with oral glucose, it's the natural fix for it. And 25 grams of oral glucose goes conscious alert. You got to remember that. Okay, oxygen. So here's my take on oxygen basically, and what I like and dislike about it. So we're gonna stick to the material, but I'm gonna talk about my feeling about oxygen later on. So oxygen is a gas that we administer in one of two forms or one of three forms, mostly through the oral or nasal passages, the oropharynx or nasopharynx. So mostly we start off with a nasal cannula or a non-air breather, depending on the severity and the condition of the patient. Any difficulty in breathing pronounced by the patient, I have difficulty in breathing, or you got traumatic or a shocky patient, oxygen is a necessary tool to fix the patient. So normally with nasal cannula, we administer about 2 to 6 liters. So you got to remember, maximum effective flow rate for a nasal cannula is 6 liters, 6 lpm, liters per minute. 2 is the very minimum. I know some doctors, they put patients on a half or a 1, but for our protocol, 2 to 6 is the range for a nasal cannula. And for a non-air breather, you guys got to remember, I've been seeing this more in the field and we've been trying to educate people. You can't put somebody on a non-air breather at just 8 liters a minute. You can't do that. Okay, that's asphyxiation. And so for a non-air breather, your range is 12 to 15 liters per minute. So I know sometimes they see people having a panic attack and they're rapidly breathing or hyperventilating as they call it, and they put them on a non-air breather with 2 liters a minute, and that's wrong. That's patient harm. Okay, remember, do no harm. In our job, we don't want to do any harm. So you're gonna put a device on a patient, use that device to its optimal potential. So non-air breather, 12 to 15 liters a minute. Okay, and here's the activated charcoal, how it used to come in back in the day. Again, tubes of 25s or bottles of 25 grams of activated charcoal. And that's just sometimes they use the cum powder, and you're gonna have to mix it with sterile water and shake it really well just to get all these settled particles from years of not using it. So activated charcoal is going by the wayside due to new studies showing that maybe it's not the most effective thing to treat, and that's why we don't carry it around here. So, broncho inhalers, this is something we assist patients with using. So, I remember from back in 2010 when Ron was saying, like, normally these medications uh, end up with a vent, with the word Ventolin, like vent in it. That's just a bronchodilator. So, anything, so Provent or Ventolin, those are your regular inhalers, bronchodilators. And when they add the word air to it, like Advair Pro Air and things like that, I think those are steroid infused inhalers. So the Ventolin is the immediate relief. The steroid infused inhaler steroids is takes very long time to infuse into the system. It's not one of these things that you just slap it on and now you should be good. Steroids takes a little bit. Even IV infused steroids tends to take from 2 to 7 hours. I'm not quite sure about the inhaled version of it, but broncho inhalers mostly are asthmatics, people with difficulty in breathing, um, things of that nature. One thing I forgot to touch up on, so there are 6 rights of medications that you need to kind of check before you actually give a patient their medicine or assist them with their medicine. So the 6 rights of medications are what? There's 6 things that have to remain right, correct, and you need to double check. You are responsible for that, not the patient. They give you something, they tell you, give me this, or give me this inhaler, or give me this pill. It is your job, not the patient's job, to make sure it is theirs. Okay? Because they could have stole it from somebody, end up giving it to them, and that may cause harm. So, um, the one mnemonic that I would like to remember, I just used the first letter. You can use whatever mnemonic you want. If you can remember all the rights, go for it. That will be a much better way of doing it. But I love mnemonics, it makes it easier for me. So the mnemonic that I normally use is Mary ran to drink Dr. Pepper. Okay, so I use every single letter from that mnemonic. So M for medication. I need to make sure it's the right medicine. That's number one. What am I giving to the patient? Is it the right medicine? Sometimes you get confused. It's a really bad call. A lot of things getting thrown at you, and you grab something you think this may look like epi, but it's not. Or you got patient an allergic reaction. You grab the EpiPen, ends up being a pediatric EpiPen, and you give them the pediatric to an adult, which is not gonna work that well. It's only half the dose, or the reverse may be correct. You may end up to a really tiny child that's having an allergic reaction. You grab the EpiPen and you did not make sure that this is the pediatric EpiPen, and you end up giving them the adult EpiPen. So, right medicine. People end up mixing pills in different bottles. They do that all the time, and you gotta love this situation when they hand you a punch bowl and all of their pills are in it. Like, I take these. Like, what am I supposed to do with that? So, this is one of these common issues that you run into. So, right M for the right medication. Okay. R, right route. You need to make sure that you are given this medicine the right route, which means if it's sublingual, you cannot tell them to swallow this pill. Sublingual, okay, which means below the tongue. That's the nitroglycerin that we end up giving. Sublingual. You can't tell them, open your mouth and toss this pill in the back of their throat. That's not how it's supposed to work. Sublingual is sublingual. Chewable aspirin says that right on the label of the bottle. Okay, chewable. It's normally pink, little tiny pink pills, and that's a right route. Okay, or inhaled, or topical, or whatever the medicine, or sub-Q, which means subcutaneous, or IM, which means intermuscular, or IN, as far as Narcan goes, intranasal. So, right medicine, right route. So, Mary ran T, right time. Okay, so what time did you give the medicine to the patient? This is a vital piece of information because this may determine one or two things. Is it time to give the patient another dose of this medicine? And this can help the doctor and the receiving facility to determine the outcome of the patient. Is it time to give the patient another dose or another compatible medicine? Okay, so you bring somebody with hypertension and high blood pressure and you give them sublingual nitro. Okay, what time did you give it? Okay, okay, hold on. I'll type it up to you. By the way, it's the rights for the rights of medication mnemonic is registered to me, so it's copyrighted. You cannot use it anywhere else. I just, I'm just kidding with you. I'll just type it right here. Mary ran to drink Dr. Pepper. There you go. Can you see it now? So, back to the lecture. So, this is why it's important, the time of the medicine. So, you gave the patient a sublingual nitro. What time was it? Or you gave the patient pain management medication or breathing treatment. What time was it? Because you can't keep overdosing the patient on the same medicine. It causes something called synergism or synergy. And synergism, imagine yourself jumping on a pogo stick. All right, you know, these pogo sticks look like a T, got a spring at the bottom, you bounce on it. So imagine yourself you jumping on that. But if I take this pogo stick and put it on a trampoline, how high are you going to be jumping? It's a regular pogo stick, but it could cause an adverse reaction. Okay, when you add one thing on top of another, that will amplify the effect or null the effect of the other medicine. So time is very important. Okay, right medicine, right route, right time. Okay, right as in not RIGHT, as in WRITE. Okay, right time. And D for right dose. So, how much do we give of this medicine? Well, read the bottle first because it tells you how many pills the patient's supposed to take if it was their medicine. When you are treating, let's say, an allergic reaction and you have to give EpiPen, okay, read what it says on the milligrams because if the you never know. Things get tossed around in the back of the rig. We all know nothing ever stays neat unless it's the clipboard. That's the neatest thing that stays clean in the ambulance because everybody's taking care of that. But as far as medicine, not a lot of people do and get tossed around in the bag. People step on it, falls off the shelf. Sometimes it will get rubbed off. But it says ped versus adult, and just read the bottle. Okay, read the tube of the IM epi. Okay, and it will say adult zero point 0.3 milligrams or 0.15 milligrams. Okay, which is half of the zero point 0.3. So the right dose is very important, and so the other letter D is going to be the right date. So you need to make sure that the patient's medicine is not expired, or your own medicine is not expired. You go to an allergic reaction and you keep on pumping them with epi. If it's expired 4 years ago and nobody checked your epi in your rig, it's not going to do any good. Same thing with Narcan. So Narcan needs to be kept in room temperature. Okay, how many people end up throwing the Narcan in one of their jump bags and throw it in the trunk of their vehicle? Okay, if there was one of you out there, I know mostly law enforcement do that. They carry their Narcan in one of their bags or on their suit or things like that. Okay, or in a little kit. But if your vehicle's parked in the sun in the summer heat, do you think that's room temperature? You wouldn't keep a sandwich there. What makes you think that a medicine is okay to stay there at 110 degrees sometimes because you have all the windows locked, so the temperature keep on rising? Sorry, coffee is really important. Yes, definitely coffee. So, so the right dose, right date, and P. P is for the right patient. This is the last step. So, okay, so I did not read this mnemonic Mary ran to drink Dr. Pepper. I found a mnemonic generator online and I put all the letters that I wanted to remember in one sentence so I don't keep on thinking about it. Okay, and it gave me a bunch of words like Mary ran to drink Dr. Pepper. This is gonna work. I'm gonna remember that for years, and so far it's worked out for the past 10. So the last stage, which is what I want it to be, is the right patient. That's the thing that's gonna hold you from giving the wrong patient someone else's medicine. So you need to make sure that this is the right patient, whether it's their name on the vial, or it's a pediatric needs to get a pediatric medicine, or an adult needs to get an adult medicine, or it's someone else's bottle. They can tell you, oh, I'm having chest pain. Can you give me my heart pills? And you're gonna end up picking up a bottle of like Vicodin, and you're gonna end up giving it to a patient, or whatever medicine that can end up lowering their blood pressure, and they're already having chest pain because their blood pressure is low. You're gonna end up killing somebody because you're not paying attention. So the rights of medications are super important. Okay, and so the prescribed medications are the inhalers, nitroglycerin, and epinephrine. So some of these patients have regular inhalers, or sublingual nitro, or topical nitro sometimes, which means like an ointment, and epinephrine, such as an EpiPen for allergic reactions. So, so the bronchodilators is basically your Proventil and Ventolin and things of that nature, used for patients with asthma, emphysema, and chronic bronchitis. It enlarges constricted breathing tubes, which means your bronchi. It's a broncho, okay, dilator. So it makes your lung, takes it from really tiny, a straw size, into something much larger that can perfuse more oxygen and help the patient breathe better. So your side effects would be increased heart rate and patient jitteriness. Okay, so they were like, oh, my hands are shaky. Like I'm feeling like I don't know what's going on. I can't sit still. Yeah, this is part of the bronchodilators. That's one of the side effects of it. Nitroglycerin. It comes in a sublingual pill, and it comes in a spray format, and it and it comes in an ointment too that we can. It's called topical nitro. Uh, that we end up putting on the patient 1 to 2 inches depending on the prescription or depending on the protocol that you're using. All right, taken by patients with history of chest pain. It helps dilate coronary vessels. So this is how nitroglycerin works. Okay, it infuses with the bloodstream the way you're gonna end up giving it, whether it's topical or a spray or a sublingual pill. Then it's gonna take blood pressure and it's gonna lower it. The good side effect of that, if patient's gonna suffer an adverse reaction to a low blood pressure, it's only gonna last about 5 minutes, and that's why they tell you to only give one pill every 5 minutes. And so it reduces cardiac demand on more oxygen because you're dilating the vessel and you're flowing more blood basically into the myocardium through the coronary arteries. Contraindications. So this is really, really important. This is a no joke. If you're gonna forget every contraindication about every medicine you're gonna learn in this class, you need to remember that contraindications for nitroglycerin is low blood pressure. Okay, so per the protocol, blood pressure need to be above 120 in order for you to give it. Or patient taking erectile dysfunction medicine. Okay, like the Viagra, Levitra, Cialis, or whatever those orange and blue pills that they sell at the res, where you just can walk in like, oh, male enhancement medicine is cheap, non-prescripted. So yeah, you can take it. You have no idea what's inside that capsule. But these medications, so the Viagra, the Levitra, the Cialis, it all started out with Viagra. It was invented as a high blood pressure medicine for women. Yes. So this medicine was supposed to lower high blood pressure conditions for women and brings it down. And they figured it didn't do what it's supposed to do. But when a male accidentally took it, like, I have a problem. And that's how Viagra became a male enhancement medication. So definitely it works by lowering blood pressure to the vasculature system, and it causes you to have the effect of Viagra. So when a patient has taken a Viagra in the like recently and now they're having chest pain, nitroglycerin is contraindicated because remember when we talked about the pogo stick and we talked about the actual the trampoline, the synergism effect. they're gonna double up the action of each other, and they're gonna take that blood pressure and all the way 6 feet under, and you just buried that patient. So do not withhold sublingual nitro or spray nitro or topical nitro in all of its forms, because the danger of having ED medicine, not emergency department medicine, ED, erectile dysfunction, okay, medicine, the dangers of it way higher than the benefit of the nitro. Unless you have a doctor on the phone from the ER, I'm like, Doc, I don't know what to do. This patient has taken Viagra yesterday morning, and today's evening he's feeling chest pain. Can I give it to him? Well, first of all, there's a time lapse that you need to be aware of. Okay, how long has it been since they have taken the Viagra? And how long has it been since they have taken the aspirin? So, like when we talked about the aspirin, the contraindication of giving aspirin if the patient has taken aspirin in the past 24 hours. So, if the patient said, yeah, I took aspirin this morning and now it's like lunchtime and he's feeling chest pain, you should withhold aspirin. You don't give any more aspirin. Okay, but the nitro part, the contraindication, is the low blood pressure issue. So the side effect is drop in blood pressure, well, which is the benefit. That's ultimately why we're trying to give it to the patient. Lower blood pressure by dilating blood vessels. Okay, we took a container and we made the container wider, so the level of fluid dropped down, and basically when they're gonna have a drop in blood pressure, it's okay. That's what we're trying to do with this medicine. And the other part that they're gonna feel, they say, I feel burning sensation under my tongue. This pill really sucks. It burns. That's what it does. Headache is also associated with the side effects. Um, let's see if it's here. No, it's not even discussing the headache part, but yeah. So you may feel, you're gonna tell the patient, you may feel dizziness, you may feel headache, you may feel burning sensation under your tongue. Those are all okay. This is side effect of this pill that I'm giving you. Okay, make them aware of it so they don't freak out, because anxious chest pain patient is not a very good patient. Their problems will only keep on getting worse. So you need to calm them down. Okay, the psychological factor is a big part of this game. That's one. Uh, Two, so epinephrine, auto injector. So you have an adult epi and you have a pediatric epi. So the concentration of this medicine, okay, not the dose of the medicine, there's two different things. Okay, so the concentration of this epi is 1 to 1,000. Okay, USP, which means there's one molecule of epi in 1,000 molecules of fluid. That's how it's diluted, okay, to become that. Um, and there are different forms of epi, but the one that we're going to be using for this lecture for an EMT basic level is the 1 to 1,000 epinephrine. They come in 0.15, and that's the pediatric, and zero point 0.3 milligrams for an adult. Excuse me. Coronavirus. No, I don't have corona. Coffee went down the wrong hole. So you have the pediatric epi is basically half of the dose of the adult epi. Then you're gonna say, well, what if I have a child that's like 200 pounds? Okay, are you talking about a teenager that's 200 pounds? Because that's doable in today's standards. Or are you talking about like a 5-year-old that's 200 pounds? But never ever exceed an adult dose. But a pediatric epi for peds, adult epi for adults. Plain and simple. Uh, and they say that what is it called? Like puberty kind of brings the child out of the child stage of medication and into adulthood stage of medication. So evidence of puberty is armpit hair, development of breasts, mustache, uh, private area hair. So epinephrine prescribed for patients to be used severe allergic reactions classified as anaphylaxis, right? So you need to also realize something about epinephrine. Allergic reaction that requires epi comes with like, how do you call it, um, like a recipe. So you need to follow the steps on that recipe. You can't skip one. First of all, the allergic reaction need to happen between second 1 to minute 15. Okay, they used to say like 10 minutes, but we've been seeing people with delayed reactions nowadays. Um, so they got stung by a bee, and they were mowing the lawn at noon, and they called at sunset. Okay, 7 o'clock at night. They think they have an allergic reaction. Is that a patient you need to give epinephrine to? Okay, definitely not. Definitely not. Okay, are they exhibiting symptoms? Are they presenting with any issues? Do they have hives? Do they have horsey voice? Do you feel the laryngeal edema? This is the larynx and edema. Fluid collection. Is the fluid getting collected within the larynx? That's also an issue. Is their blood pressure dropping to critical levels? Is it below norm? Right after the exposure to the allergen. We got to remember a person have to be exposed to the allergen twice in order to be allergic. Thus, makes all children born non-allergic. Okay, because their system is brand new format, brand new defrag, and this pediatric, okay, have not been exposed to allergens twice yet. So they may get stung by a bee for the first time in their life, and they're gonna be okay. The second time is when the system gonna register the allergen as this is something bad. Next time it will be exposed to it. The patient gonna go like, nah, fight it. Throw everything you have at it, and that's how you get the anaphylaxis. It's a systematic attack on an allergen that got introduced to the system. So your whole system will goes on a fire sale, and fire sale means everything must go. Okay, so allergic reaction is like one of the reasons why you would give epinephrine and not an excuse to give epinephrine. So you need to be convinced that the patient is in an allergic reaction, having an anaphylactic episode. Hives, drop in blood pressure, sweating profusely. This is a big sign. Okay, hoarseness, they feel their throat closing, even if you can't hear it. It's like, I feel my throat closing, something's in my throat. Okay, you need to understand that this just gonna double up in speed, and it's gonna double up in danger to patient health. So you need to be proactive. You need to recognize these signs. But I had this patient years ago where he said, I was mowing the lawn, I got stung by a bee. I didn't think anything of it. But then I went to bed at night. I'm like, what if I'm allergic? And that's why I called 911. So why we went is not to give him epi. We went because when his wife found out that he got stung and she's afraid that something gonna happen to him, like he's a worrywart, and so was she. So they went to grab an epi that they acquired from a yard sale. Not his. He's never been allergic, never been prescribed epi. They found it at a yard sale. I'm like, look, comes in handy someday. Oh, sure did. So his wife grabbed the epi and almost like killing a vampire. When he showed me his leg, apparently his wife went like, Jesus! And she stabbed him in the knee, okay, with the epinephrine needle. And you know how when you push the EpiPen into someone's extremity, the needle retracts? She slammed it so hard, she bent the needle at the end of the bone where the needle wouldn't retract all the way in. And so that's why he called us, because his leg hurts and he doesn't know if he's allergic 7 hours later before he went back to bed. True stories. This is EMS for you. You can't make this stuff up. So you need to make sure the patient in an allergic stage. You know, they're anaphylaxis. How does it work? So it's a vasoconstrictor. So remember when we talked about the human body is just a fluid and a container. You maintain the container to maintain the fluid, and you maintain the fluid to maintain the container. In this case, when I told you your body goes on a fire sale, which means your body takes the vessel and stretches it. So there are three different types of tissues in the human body. Permeable, which means let things through, almost like a filter. Semi-permeable, which means a filter with really small holes that does make some things go through and certain things stays in. And non-permeable membrane, okay, or impermeable membrane. So
your body takes all these tissues, all these membranes, and stretches them. It's a fire sales trying to push as many things out as possible. It doesn't know where the allergen is. It's almost like, you're watching a military movie and a bunch of people got attacked, and this guy grabs the belt-fed machine gun, pulls the trigger, spray and pray, and goes 360. He have no idea what's going on, but everything must go. So this is what your body does, and this is what causes the issue, because some of the fluid that escapes the vasculature system is a fluid that's vitally needed to keep the patient alive or to keep human body alive. So the sweat that leaves need to ring red flags in your head. Sweat is an important fluid. Okay, sweat is just as important as blood, if not even more important, because when blood comes out, you will be already alerted that this is a problem. You need to take care of it, and this patient's bad. But how many times you saw a patient sweating profusely and you did not pay the same attention to that sweat? Sweat is a really important indicator. What is the biggest organ in the body? Skin. Skin is the biggest organ in the body. If the biggest organ in the body that you can see without an x-ray or an MRI, you can see that organ, and that organ is struggling, and it's sweating profusely. Isn't that an issue? If the biggest organ is having a problem, the whole body got a problem. Okay, the hives is problem with that organ. Paleness, which means lack of circulation, problem with that organ. Lack of perfusion, diaphoresis, which means sweating profusely. It's almost like the patient fell in a pool and got out with their clothes on. Okay, their clothes will be stuck to them. They're sweating so much. So that's not normal. This type of sweat is not normal. Somebody sweating that bad, their skin, you touch their skin, and it's like sticking to your gloves. All right, that's a problem. So that's the type of patient. So that we give epinephrine to. So vasoconstriction would mean vessel. We constrict the vessel to increase the amount of fluid in it. That's how we combat anaphylaxis. Side effects: increase in heart rate. I love that when patients tell me, "What are you allergic to?" And they say, "I'm allergic to epinephrine." What does it do for you? "Oh, make my heart race." Okay, that's what epinephrine is supposed to do. Same thing when they tell you, "I don't like nitroglycerin. It makes my blood pressure go down." Well, that's what it does. So now we're talking about Narcan. So Narcan is an antidote to patients who are unconscious and in respiratory failure and taking narcotics. So, how does Narcan work? Basically, Narcan is an opiate receptor blocker. Okay, so this is how now imagine a receptacle on the wall, an outlet, and you plug your cell phone into it all the time to charge your cell phone. So your charger is the opiate, and the receptacle is the receptacle and the opiate receptor neuro end of the nerve itself. Okay, so this is how the opiate comes in, like a cell phone charger plugs itself in, it doesn't stink. So Narcan is like electric tape to cover this receptacle. That's how Narcan works. It's an opiate receptor blocker. So you give that to patients who are unresponsive for an unknown reason, constricted pupils, and snoring respirations. So those type of patients are mostly why we use Narcan, why we give them Narcan, which potentially overdose patients. Sometimes overdoses from um, cocaine will not work as well because cocaine is not opiate. Narcan is morphine, is a hydrocodone, Vicodin, things of that nature. Fentanyl, those are all opiates. So when patients end up taking those, they end up suffering uh, this opiate overdose. Constricted pupils, snoring respirations, unresponsiveness to almost all stimuli. So it does not work if the patient had narcotics, like we were saying, uh, and forces protection medication. So I'm not sure where does this fit in the Narcan portion. It says atropine auto-injector to treat responders in the events of an attack. So we used to carry those atropine injectors just by themselves, like called atropine pen, just like an EpiPen, but got atropine instead. and those are for organophosphate poisoning. All right. So organophosphate poisoning causes symptoms called sludgem, which is S for salivation, L for lacrimation, and U for urination, D for defecation, and M for meiosis, and G for gastric upset. So I'll type that in here too, just in case if it pops up on your paperwork somewhere. Sludge. There's actually an E in there for emesis, which means vomiting. So this is the mnemonic for organophosphate poisoning, and we used to carry that when you go to farms and things of that nature, and the farmer gets out. He's have meiosis, means constricted pupils. They come out constricted pupils, and they're sweating, vomiting, drooling, the pale, pasty, defecated themselves and pissed themselves. So you need to worry that this may not be your regular issue. And if a second person comes out with the same problem, you need to understand that they may have been messing with some phosphate, okay, or organophosphate, trying to fertilize soil, kill larvae, things of that nature, and now they got it in their system, and now they're to the point that they're poisoned with it. So it's used for organophosphate poisoning. So we used to carry atropine injector, and what it does, it increases your heart rate, because part of the side effect is bradycardia. It blocks the enzymes that make your heart beat at its normal speed. Okay, so oral glucose administration video. We're just gonna click on that and see it real quick. Hopefully it works. And this got open.
The brain is very sensitive to low levels of sugar. Oral glucose usually comes as a tube of gel. Apply with a tongue depressor and place between the cheek and gum or under the tongue. Swallowed glucose is easily absorbed into the digestive. Brain is very sensitive to low levels of sugar.
I'm not sure
Oral
if you
glucose
can hear
usually
this,
comes as a tube of gel.
but
Apply with a tongue
they're
depressor
applying it
and
to a
place between
tongue
the cheek and
depressor.
gum or under the tongue. Swallowed glucose is easily absorbed into the digestive tract and bloodstream, which carries it to the brain. Quick administration of oral glucose when the patient is conscious and can swallow is critical to reverse a potentially life-threatening situation.
It's talking about that patient need to be conscious and alert to administer oral glucose to them. Moving on. General information about the medication. So medication names. Each drug listed in its generic name, and each drug has at least three names. So it has a chemical name, generic name, and brand name. One or more trade names may be given by drug manufacturers. So what you may need to know about giving medications to patients. So the indication, the contraindication, side effects, and untoward side effects. Forms of medication. Compressed in a powder-like or tablet, liquids, gels, suspensions, fine powder, gases, and sublingual sprays. So these are type of medications. So compressed into a powder or tablets. Remember, we talked about aspirin pills, liquids, and gel. So liquid, as far as when we talked about charcoal, that's in a liquid format. Gel, either the nitro paste or the oral glucose. Suspensions, it comes in different formats that you're gonna have to mix it in order to make it into like either cream or a gel or something absorbable by one of the mechanisms in the human body. Fine powders, they used to I think they used to make nitro powder back in the day that you actually also put in the patient's cheek on the inside. I remember my grandma used to have it. That was back when I was like 6 or 7. Gases such as oxygen and sublingual sprays also such as nitro spray. So administration, how you build a good clinical judgment to administer medicine. Administering medication with a serious responsibility. Patient medication is serious responsibility. Know the medication and use good judgment. So medication authorization. So offline medical directions. Do not speak to a physician and use standing orders. So your orders tells you to put patient on a non-rebreather if they're having difficulty in breathing. Non-rebreather ranges are between 12 to 15. That's called an offline order. You can use it all the time and you can refer to it. Online medical direction, which means you picked up the phone and you went like, hey doc, I have an issue, something that I can't handle via regular online directions, via orders. What do you want me to do? You speak to the physician directly, you listen to the orders, and you repeat the orders back. Doctor tells you, okay, give 3 pills of sublingual nitro. You can't just say, yep, I'll do it. Because he may say a free as in F-R-E-E instead of 3 as in T-H-R-E-E. Okay? So you give 3 pills of nitroglycerin, unless you're German. That's 3 for Germans. 3 pills of nitroglycerin sublingually. You need to repeat the order to that physician. And I'm like, yes, doc, you said I should give 3 pills to the patient sublingually. Don't argue with them. Just repeat the order. It's called echo. Okay? It emphasizes good communication, because when you say it back to the doctor, he may have said it wrong. There's 1,000,001 things going on at the ER. So when you call, probably not the best time. Most of the times are not the best time. So when you call and it's courtesy from the doctor, he's trying to look out for you. So you look out for your patient, because you are your patient's advocate. If the order did not make sense, okay, repeat it to the doctor. I'm like, doctor, I did not copy. Did you say give 4 injections of IM epinephrine to the patient? And if doctor says yes, go ahead and give it. Okay, that's called repeating the order to the doctor. Okay, this is the echo system. So you listen to the order, then you repeat it back. This way the doctor made sure that you heard him correctly. Okay, and ask for clarifications necessary. So I'm like, doc, I have never given this medicine. Is it okay with you to go over it with me a little bit? Okay, and it's a common, sometimes medications goes years. Okay, we have not administered those medicines to patients, just never had the chance, and it's okay to ask. Like, doc, I have never given such and such medicine. Can you quickly talk me through it so I don't make a mistake? They will be happy to help you. They'll never say, nope, it's someone else's problem. You'll never hear them say that, because it is their responsibility to guide you into better care of the patient. Okay. Oh, this one got one less right than what I told you. So there are 5 rights of the medications. Do I have the right patient? Is the right time to administer this medicine? Is this the right medicine? And is it the right dose? And am I given the medication by the right route of administration? So sorry, I missed one of the letter D for documentation. Always document what you gave and what time you gave it. When we were discussing the 6 rights of medication, but apparently there's 5 rights. Now you have one more. Twice as good for half as much, right? Okay. Think about it. What would be the potential risk of these 5 rights that you're going to end up if you miss one? And we already talked about that. So, routes of administrations, oral or swallowed, sublingual, which means under the tongue or dissolved under the tongue, inhaled, breathed into the lung, usually as a tiny aerosol particles, such forms of inhalers such as gas or such as oxygen, intranasal, which is an intranasal spray into the nostril, and intravenous or injected into the vein, okay, and intramuscular, such as IM, okay, and that's how we give epinephrine, and subcutaneous, which means into the fatty layer of the tissue or under the skin, interosseous. The osseous space is within the bone marrow okay, bone marrow cavity, and you see some of the medics, they drill a needle into the interosseous cavity, okay, into the shin or the shoulder of a cardiac arrest patient that needs medication. The reason behind that, if you cannot get a good vein in a very time-sensitive matter to administer time-sensitive medicine, that will lead to better or worse patient outcomes depending on the delay that you're going to be facing. You will have to drill into the bone, because at the end of each bone there's going to be a vein that's going to be carrying the medication just like a regular vein does, and that doesn't collapse unless that extremity is actually traumatically injured. That's when you end up avoiding that. Endotracheal, which means the end of the trachea. Endotracheal. That's when we put a tube down the patient's throat, okay, and into the lungs to breathe for them via bag valve mask, and that's called intubation. Endotracheal, into the trachea, at the end of the trachea, sprayed directly into the tube and inserted. That's inserted into the trachea. Yes, that is a route of medications, not the preferred, but it's a route. Okay. Pharmacodynamics, okay, the study of the effects of the medicine on the body. What does it affect, and how will this medication affect this patient specifically, and patient-specific factors change how the medication works, which is true. And after administering the medication, reassess the patient and clearly document medications administered. So why isn't that one of the 5 rights of medications? I'm just asking for a friend. Because it has 5 rights, but one of the things that you have to write is the right documentation. So, medications patients often take. So here's that Advair that I was talking about. This is an infusion of a steroid. Okay, so this medicine is normally kind of prescribed for daily treatment management of respiratory disease. It should not be used for emergency treatment or an acute attack breathing difficulty. And so, like when we talked about Ventolin or Proventil, these bronchodilators, this is a steroidal combination of medicine, okay, that the patient end up taking as a daily regimen, not as a reason why we should keep on just giving it because it's an inhaler. That's not an inhaler. That's not what that means. Okay, this is a steroid disc. So, herbal agents. This is what we end up finding the patients on sometimes, and you need to understand what some of those stuff mean. I can text you this list, but we can go through them really quickly. So the Genco, pretty much dementia, poor circulation. St. John's wort is for depressions. Echinacea, I think, prevention of treatment of common cold. Garlic, high cholesterol, ginger, root, nausea and vomiting. Saw, palmetto, swollen prostate. Hawthorn leaf is for heart failure. Evening from primrose oil for premenstrual syndrome. Then feverfew leaf, migraine, and kava kava for anxiety, and valerian root is for insomnia. So assisting in IV therapy. So I'm so glad that the times have changed and this is a thing that we do right now. Um, so ways that the fluid medication can be administered to the patient. So the heparin lock or saline lock. I prefer calling them saline lock. Hep lock is an old outdated term. They used to call it hep lock because it was a route to administer heparin, which is an antiplatelet aggregator. So what basically they used to inject heparin through it, and they leave a little bit of heparin in there so it will continuously infuse into the blood to prevent a blood clot from forming at the end of that IV needle. Okay, so saline lock, a catheter placed into the vein, cap lock placed over the catheter, and a lock contains port for administering medication, and normally called a lower lock, which is it's like a spring button that the syringe connect to it, and we push medicine. It's self-locking. I love it. So, ways for the fluid medication to be administered, well, via into the vein. So a traditional IV bag. Break time. Do you guys want to take a break time? Gonna have to wait a minute for everyone to take this break time to get the message. Do you guys want to have a quick break for like 2 to 3 minutes? No? I'm gonna continue until I see the message come back. So, traditional IV bag is a bag that hangs above the patient, and no, not 10 minutes, buddy. Jordan Smith asking for a 10 minutes break. Uh, okay, any other voters on break time? Any other takers on break time? Going once? Okay. So, let's finish with this lecture, then we'll take a quick break. We're not going to discontinue the stream. We're just going to keep on plugging in until we finish. So, hang the bag above the patient and consistently flows with medication to the patient. So, it's a clear plastic bag connecting to the bag fluids, and with a catheter, there's 3 ports, a drip chamber, a flow regulator, and a drug or other. Okay, Kristen says yes. So setting up the IV administration, just gonna go a few more slides, and we're gonna take a quick break and come back to this pharmacology because it's kind of important. It's maybe a boring subject, but we're gonna be like 2 to 3 minutes break. Run up to the bathroom, go grab something to drink, do whatever, and we're gonna come back. I'm just gonna carry on with the lecture. Just I would appreciate it if you'd send me a message that we're back from your break, so I would know that some of you are paying attention. So I'm gonna set the time here for the break. So setting up the IV bag is really simple. Basically, you uncap this. This is called this is the spike for the drip chamber. So you need to be careful. This is considered sharps. This does not go in the regular garbage. You can't just throw this whole line into the regular garbage. That's considered sharps. Sharps go in the sharp container. So what you do, you take, can you see my mouse? You take your shears, and when it's time to throw that away, you cut it right about here, okay? And throw this part into the sharp container, okay? So you uncap that. Oh, you guys already took a break? It's pretty funny. Wayne and Pam said they're back. Okay, then you hang the bag, you spike the bag into the bag, then you lock the wheel that's right here in the left hand, as you can see. You roll that rolly clamp all the way down, and you squeeze this drip chamber to fill it halfway up. Please, please, I beg you, I'll buy you coffee. Do not fill that drip chamber all the way up to the white plastic, because this has a benefit. That's how we count how much fluid drips into the chamber, so that we know how much medicine are we given and how fast are we giving it. So you need to give us some room. Normally you will see a ghosted line across the chamber. That's where the optimal fluid level need to be. A little bit high, a little bit low, that's fine, but please don't bring it below 30% of the chamber. If the fluid level is here, that's not good, because that can promote blood air bubbles traveling through and into the patient bloodstream. So please don't do that. Halfway is good. We all agreed upon that. And this is the rolly clamp. That's how you turn off the flow. If you roll it up, it's open. Roll it down, it's shut. And okay, maintaining an IV. So let's take a quick 2 to 3 minutes break. Please, when you get back, shoot me a message. I have a few more updates about the coronavirus from East State, from New York City. This is kind of important for me too, so I would like to read that. We'll reconvene in about 3 minutes. So my clock showing 7:35. I'll be back at 7:38. Probably by the time this transmission gets to you, it's like a minute or so later. So don't freak out. It's okay. So. Okay, we are back. Um, Everyone's back? Okay, so we are back with maintaining an IV fluid. So troubleshooting problem. Okay, constricting band. Left in place by mistake. So the the tourniquet that we wrap around the arm, the little blue or orange, depending on the kit that you're using, or sometimes white. They come in multiple colors. Those are definitely a problem. Don't pay attention. Don't leave those on. Remind the medic if the medic started it. Don't leave that on as well. So that's called the tourniquet. Or sometimes like in traumatic tourniquet that we used. I have a tourniquet application video on my channel if you'd like to check that out too. But those also will impair fluid flow. So flow regulator would be left closed. Pay attention to that. Clamps, there are clamps in the middle of the IV line that are sometimes shut. Also pay attention to that. Tubing is kinked. That's a big thing. Sometimes the patient lay their arm wrong or whatever, and they impair fluid flow. Um, and the line pinched under backboard in trauma conditions, trauma situations. Adjust flow rate properly and monitor IV sites for infiltration. This is a problem. If the IV needle get pulled out of the vein just a little bit, it may sit in between the vein wall and the subcutaneous layer or muscle tissue, and it will balloon up. So pay attention to that, because some of the medications that can be administered via IV can cause tissue necrosis, which means it eats away tissue. It's very, very harmful to the patient. And chapter review. So we are done with pharmacology. Anybody have a question? These are basically the medications that we go over and we assist the patients with. And we're going to be moving on to respiratory before we go into cardiology. So I'm going to make this sweet and easy for you. If you have any questions, please let me know. We are casting the respiratory emergency chapter now. So we're going to be talking about COPD, or chronic obstructive pulmonary disease, subcutaneous pneumothorax animation, which means an infiltration to the lung or lung wall that's going to impair the lung functionality, and metered dose inhaler videos. So topics, we're going to be discussing respirations, breathing difficulty, respiratory conditions, prescribed inhalers, and small volume nebulizers. So what is respiration? So the diaphragm, if you remember from my class from last time, which was the very last lecture that we have discussed at JCC, and there we go. We have the ban now, and nobody can go anywhere because of the coronavirus, or as some guy at the store called it, Karuba. I know what you got. You got the Karuba virus. So that was nothing. But so the diaphragm, when we made that plastic lung, the diaphragm pulls down, okay, and decreases the interthoracic pressure and inflate the lungs by pulling air into it, okay, from the uh, from the abdominal cavity. During normal respiratory cycle, the diaphragm and other parts of the body work together to facilitate the inhale and exhale processes. Okay, so as you can see, here's the diaphragm. Diaphragm pulls down, decreases the air volume into the walls here, and inflates the lungs. So, the inspiration cycle. So, it's an active process, uses muscle contraction to increase the size of the chest cavity. And the intercostal muscles, which means the muscles that are between the ribs, that's called an intercostal space. There's muscles in there that helps your ribs open up and your thoracic cavity to increase in size. Okay, so intercostal muscles contract, and diaphragm lowers, ribs move outward, upward and outward, okay, like a bell, and air gets pulled into the lungs. So this is the inspiratory phase of the respiration. The expiratory phase of the respiration, or expiration. So it's a passive process by letting go of everything, because all these muscles under tension when you inhale, you let go of everything, everything gonna get pulled back in, almost like a rubber band. Uh, Ribs, muscle diaphragms relax. The size of the chest cavity decreases and air flows out of the lungs. So, breathing sufficient to support life. All right. Signs. No obvious distress. That's for adequate breathing, obviously. Ability to speak full sentences without having to catch a breath. So, you will have this patient. We always will have this patient. You get called in. I'm having trouble breathing. I went to the shop and I went and got all these things, and now I can't catch my breath. Seems like that I have a problem. Okay, well, there is an issue that this patient is running with these sentences and complaining of difficulty in breathing. Is it difficulty in breathing that's a sudden onset, or is it a chronic issue that's coming up? Normally, those patients in severe respiratory distress, they're going to be going like, I can't, I'm, I'm trying to catch my breath. Those are the people that you need to ultimately increasingly worry about. And normal skin color is part of adequate breathing, mental status, and orientation. So maybe determined observing rates, rhythm, and quality. So you always need to look at the respiratory rate, and you need to look at the rhythm of it and the quality of it. So shallow respirations are no good. We have a problem. Super deep, ineffective respirations are no good. We have a problem. And the rhythm. So the rhythm, if it's inconsistent, you may have a bigger problem if the patient has suffered a traumatic injury, especially affecting the head and spine. Head, neck, and spine injuries will cause an irregularity in the rhythm, and called Cheyne-Stokes respiration, which it normally you breathe so deep and you exhale. Breathe so deep and exhale. But when you get this patient that's breathing deep, 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 shallow, 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 deep, 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 shallow, shallow, shallow. Okay, that's called Cheyne-Stokes respiration, and it's a sign of a brainstem injury, potential fatal. So you need to worry about those things. So 12 to 20 for an adult, 15 to 30 for a child, and 25 to 50 for an infant. We always going to get those calls of, my child is breathing funny. And you look at the child, they're breathing 50, like breath almost every second or every other second, okay? And that's normal. It's an infant. They need to breathe 25 to 30, okay? But for an adult to breathe 25 to 30, they're bound to pass out because they're moving a large volume of air and they're exhaling a large volume of carbon dioxide. So rhythm usually regular, breath sounds normally present and equal. Equality in breath sounds, right and left, is also an essential to assessing patient care when it comes. So inadequate breathing, breathing not sufficient to support life. That's bottom line of it. Signs, rate out of norm and irregular rhythm, diminished and absent absent lung sounds, poor tidal volume. Tidal volume, remember the tide, the wave, okay? So tidal volume is how many rushes of air that fills the capacity of the lung. So average adults have between 350 to 550 mLs to fill their lung. So you got to remember, when you have this, your BVM, how many mLs in a BVM? There's about 1,500. Okay, so you need to make sure to be careful to only inflate the lungs if you're assisting with respiration or if the patient unresponsive. So only when you inflate the BVM, to stop when you see chest rises. Don't keep inflating, because when the lungs are full, they're not going to accept more air. Then air is going to flow into the epigastric tube and it's going to go into the stomach. And if the patient's unresponsive, When that air gonna get behind digested food that turned into a liquid, guess what's gonna come out first? The liquid, and you don't want to deal with that. So, structure of an infant's and child's airway is different than an adult. So they have a smaller airway, easily to be obstructed. Um, Proportionately larger tongues because children are weird, okay, especially infants. They're so like heads this big, bodies this small, and when they grow up, all these gonna normalize and equalize and come up to an adult size structures, especially tongue, airway, things of that nature. So when they're that tiny, their lungs are the size of the thumb portion of the glove. Okay, that's not a very big lung. It doesn't take much to block that and causes mass problems. Um, Smaller, softer, more flexible trachea that it doesn't take much to collapse. Less developed, less rigid cricoid cartilage, which means this is the cricoid cartilage. That's what gives the trachea its shape. It's less rigid. Heavy dependence on diaphragm for respiration. So they're always, their stomach moves up every time they breathe. Okay, they depend on the diaphragm a lot of the times. So the pediatric notes for inadequate breathing is the nasal flaring. So every time they take a breath, their nose flares. The grunting, okay, when they breathe, they go like, what they're trying to do is build up something called PEEP, which means peak expiratory pressure, and that's a sign of a bad respiratory problem. And the seesaw breathing, okay, that goes up and down. So every time, so seesaw and retraction breathing. So the retractions, every time they're trying to take a deep breath, the skin on their lungs, okay, and their stomach collapse. They're trying to go like, they're trying to breathe because they're constricted as far as the airway, the nasal passages, things of that nature. So that's called retractions. Retractions are very exhausting to a child. They get very, very tired from it, and you need to deal with that quickly. So, inadequate breathing, assisting with ventilation with supplemental oxygen. You have a pocket mask with supplemental oxygen. Some of these pocket masks have a side port valve and an oxygen tubing that you can connect to an oxygen tank, or two rescuer back valve masks with supplemental oxygen. Is one of the ways that we can fix that issue. So, assisting with ventilation with supplemental oxygen, flow restricted, okay, oxygen powered ventilator devices, okay. So there are things that you put the mask on, and there's a button on the mask. It looks like a non-rebreather, but it have like a cushion, like a BVM cushion, like on the BVM back valve mask, face mask. So when you hit the button, it will give a certain amount of oxygen to help the patient breathe. And one rescuer back valve mask with supplemental oxygen. So, chest rise and fall should be visible with each breath. Adequate artificial ventilation rate, 12 breaths for an adult, okay, and 20 breaths for infants and children. Increasing pulse rate can indicate inadequate artificial ventilation for an adult. So, when an adult becomes tachycardic, that means it's a sign they may have a shortness of breath or breathing problem. Decreasing pulse can indicate inadequate artificial ventilation in a pediatric patients. So most of the peds, the preemies and neonates, especially if they're just born day ago, 2 days ago, or just now, if they have a low heart rate, chances are they don't have a cardiac problem. Chances are it's a respiratory problem that we need to deal with. So how you might recognize the progress of adequate breathing to inadequate breathing for a patient, and how might you change how your patient can change during transition. So you have a patient with difficulty in breathing. They may present pale. One of the quickest signs to kind of pay attention that you may have a problem. Again, we said the skin is the biggest organ in the body. If the skin is struggling, the rest of the body is definitely struggling. We need to find out where. So patient posturing, which means they're in a tripod position. Either they're standing with their hands on their knees or their elbows on their knees on a chair, or keeping their back straight and they nod every time they take a deep breath. Okay, they pull their back out. They're using accessory muscles to facilitate better breathing. So difficulty in breathing, patient's subjective uh, perception. So they can tell you, I'm having difficulty in breathing. Your judgment means nothing. If the patient says it, you are not the person to say, no, you don't. You don't have difficulty in breathing. Okay. You are the person who's going to say, all right, well, let's see what we can do to help you with that. Okay, so I'm going to put you on oxygen, or I'm going to see if you need medications to help the oxygen infuse better. Feeling of labored, that they're tired, difficult breathing, they're tuckered out. Okay, so breathing is a muscular process primarily. Those muscles, just like any muscles in your body. So you go from a couch and you hop on a trampoline and you jog for an hour. Okay, so you did it from the couch to the trampoline for an hour. What do you think going to happen to your leg muscles? So when you have somebody who having trouble breathing, those people with chronic respiratory issues, they tend to wait because they deal with that 3 or 4 times a day. And they wait, they take their medicine, they catch a break, they sit down, they relax, it goes away. So sometimes they do that and it doesn't work. And by the time they call you, you are the last resort. And that's why they called you. So the amount of distress felt or may not be reflected on actual severity of the condition. So treat the patient, don't treat the monitor. Okay, let me repeat that. Treat the patient, don't treat the monitor. I'm going to type it in here so you'd all remember. Went back in the slides. My apologies. Wanted to type something. Send. There we go. Now it's documented. So treat the patient, don't treat the monitor. In other words, that mean you may put a pulse ox on a patient that's having difficulty in breathing. They're cyanotic, which means pale ashen skin. There's blue around their lips, blue in the fingernails. Okay, that's signs of cyanosis, and the pulse ox may tell you SpO2 is 100. Does that mean you shouldn't put a patient on a pulse ox, or you shouldn't put a patient on an oxygen? Which one is more accurate? Because sometimes if patients suffer carbon monoxide poisoning, carbon monoxide will show up as 100% on a pulse ox because your pulse oximeter does not measure oxygen. Your pulse oximeter measures gas infusion into hemoglobin. That's how it works. So when the gas infusion into the hemoglobin says 100, that could be nitrous, that could be nitrogen, that could be carbon monoxide, that could be cyanide. You don't know what that is. Okay? So patient complaining of difficulty breathing, despite of what the pulse ox is going to say, you need to react accordingly and put the patient on oxygen. Treat them per the protocol. Even if the monitor tells you otherwise. Patient overrules the monitor. Patient says, I'm having pain. If they don't look like in pain, does that mean they're not? Okay. Patient's complaint comes first. Treat patient complaints. So, remember when we talked about posturing? So this is the tripod. Those people that are normally look, you can see, you can assess the picture of the patient. He's kind of like sweaty, tired. He's looking into the distance. He's not looking at you like you're trying to make a human-to-human connection with the patient, and they're completely ignoring you. They have a serious problem, especially when it comes to children, because children tend to look around a lot. And when you get to that child that's looking into the corner of the room and they're just breathing, you know, they have a bigger problem than you, stranger, being in their house. Okay, so the onset, when did it start? Because that's a problem. We need to find out. Did this start 2 weeks ago that you have not treated? Or did this just come on right now and now you are in that kind of shape? Provocation. What brought it up? Okay, what caused this? Were you dusting? Were you mopping? Were you working in the shop? Were you in a farm? These are all important questions. Quality. Do you have a cough? Are you bringing anything when you cough? Is it productive or is it dry cough? Or is it just all around wheeze? Radiation. Does it hurt? Okay, does it go anywhere? severity on a scale of 1 to 10, how bad do you classify your breathing? And how long have you been feeling like this? So observing, pay attention to altered mental status or limited mental status. Unusual anatomy, barreled chest, which means it started to round off. Uh, Patient's position, tripod or sitting with feet dangling, leaning forward. Um, so work of breathing. Is there retractions? Does it seem like somebody holding something against their face that preventing them from taking a full breath? Use accessory muscles, flaring of the nostrils, pursed lips. When they exhale, do they go like, that's also a problem because they're trying to have a residual air into their lungs to help perfusion. Um, Number of words that the patient can say. Are they just flying, like how I'm flying through this lecture, or are they taking a word every breath or so? You know, can you only hear it one word at a time? So, other things to observe is are they pale? Are they cyanotic, which means blue in the lips? Flushed skin, which means redness. That's a very adequate sign to kind of, when you go to the CO call, you have a CO monitor activation, no illness, or CO monitor activation with illness. And you get there and the patient is super red and they're having trouble catching their breath, and you need to suspect something. You need to suspect something's going on because CO, carbon monoxide, actually flushes the system, causes the patient to become red. Pedal edema. Are their feet swollen? Okay, that's a sign of a heart failure. So when the heart have trouble evacuating blood from the vena cava, blood tend to settle in the furthest point closer to the gravity, so their feet swell up. All right, so that's fluid leaving the blood and filtering right through the vasculature tissue and getting trapped underneath the skin, okay, or within the epidermis layer or whatever. So you need to assess for that. Sacral edema, um, and oxygen saturation, SpO2, regarding reading less than 95% on the pulse oximeter. So your patient need to be between 94 and 95, between 95 and 99% um, on room air if they don't have trouble breathing. When they have trouble breathing, these numbers need to be skewed. If they're having trouble breathing and it's 100, you need to think of something else. What caused that? And here is some picture of a guy with a nasal cannula, how the nasal cannula is supposed to be applied. You can see the JVD, with jugular vein distension, that may be causing some of those issues. So that means there was backed up blood pressure somewhere. So the noisy breathing, the audible wheeze, one of the easiest things to get trained on. Okay, can be heard without a stethoscope. Uh, I can tell you, 9 out of 10 patients, I have 1, 2 with difficulty in breathing. You can hear the wheeze. You come in and you can hear every time they breathe, and you can tell that seems to be like a wheezing problem, right? That's probably what's causing uh, the difficulty in breathing. The gurgling, that sound, that's something bubbling or percolating beneath in the lungs. The snoring, uh, the crowing, then the stridor and coughing. So the auscultation, listen to lung sounds on both sides, high and wet. Okay, so you listen high and you listen wet, where the moisture areas are, where like closer to your armpits, into the side of the lungs. If the patient's shape prevent you from getting to a solid bony structure where you can listen very well, you can go through the back and you can listen to the lungs. So like we're seeing here in this picture, you can listen to the lungs through there too, not just in the front. So auscultating for wheeze, which is high-pitched noises created in air moving throughout narrow passageways, and crackles and pops that normally happens, which is bubbling sounds with respiration caused by fluids in the alveoli. You can hear things, bubble. The rhonchi, the lower pitch sounds, okay, resembling snoring or rattling noises within the lungs, caused by secretion in the large airway. The stridor, high-pitched noise in the upper airway. So you get that with children a lot of the times because there's obstruction, either like in the field they call it lung butter, but it's not. It's something got coughed up and didn't make it all the way through because infants and children don't know how to clear their throat that well, not like an adult. Um, and that will cause the stridor noise, or sometimes they have uh, laryngitis, which means an infection in the larynx, or epiglottitis, infection in the epiglottis. So these are infections that may obstruct the airway and will cause the stridor. Evaluation of vital signs and changes may include increase and decrease in pulse rate, changes in breathing rate, changes in breathing rhythm, and hypertension or hypotension. So breathing difficulty may assure adequate ventilation. Um, Breathe and begin artificial ventilation. So if it's not good, start breathing for them or help them with the breath. That doesn't mean they have to be unresponsive in order for you to apply a back valve mask. You can put a back valve mask on and assist the patient. So every time they take a deep breath, okay, you can help them by squeezing the bag and giving them more oxygen, making the breath easier to inhale. If breathing adequate, use a non-rebreather mask at 15 liters per minute. So this is how you set it up. That's the regulator on the O2 bottle. Place a patient in a position of comfort. You can't lay those people flat. Remember, those people are having trouble breathing. They're sitting up for a reason. So the position of comfort, there's limitations. They cannot stand in the back of the ambulance. They cannot, sit on the side of the stretcher. They have to be secured on the stretcher, but in a position of comfort. Sir or ma'am, is your back okay to be like that? Do you want to get lower, higher? Can I help you with that? Administer prescribed inhalers. So if they have one, help them with it. Administer continuous positive airway pressure, CPAP. So the benefit behind the CPAP mask. So when we talked about this patient waited, okay, they get these episodes 4 or 5 times a day, and they have waited until they called 911. Those patients are definitely tired of breathing. You don't want that to turn into respiratory arrest, definitely. So you need to help the patient by making it easier to breathe. So how do we do that? We apply a CPAP on their face and we strap it to the back of their head. And what the CPAP gonna do, it's a continuous positive airway pressure. Okay, so it's constantly flowing air to fill up their lungs. So you need to coach the patient through the CPAP process. They have to be alert and they have to be oriented and follow commands. Okay, well, they have to be an adult above 16 years old or better. So you're going to put it on them. They're going to freak out because they're either claustrophobia or it's weird because it's literally pushing air down their mouth. So constantly. So then when they need to breathe, they need to relax their throat and allow the CPAP to fill up their lungs. Okay. Then when they need to exhale, they need to exhale forcefully so they can create extra pressure in the mask and it will relieve the air that they exhaled. So that's, in the beginning, it's a little bit frustrating to get the patient in sync with how to use the CPAP, but the benefit of it, you can tell that the patients start relaxing. Like when you put it on, the first few minutes you may not see it, but then after that, they're going to start relaxing because now they can feel their muscles are relaxing a little bit. Similar principles, blow by oxygen or air continuously into at lower pressure into the airway to prevent alveoli from collapsing at the end of exhalation. Um, that can prevent fluid shifting into the alveoli. So one of the benefits of the CPAP that it's going to build enough pressure to shift fluid back into the bloodstream away from the alveoli. So it doesn't fill up and drips into the alveoli and causes like alveolar occlusion. So common uses: pulmonary edema, drowning, and asthma and COPD, and respiratory failure in general. So CPAP is a good device used for that person that's bobbing up and down, taking really deep breaths, nothing's working, and they're weak and tired and lethargic. So CPAP would benefit them. Contraindications. Altered mental status, obviously. So if they're confused and unresponsive, don't do it. Lack of normal spontaneous respiratory rate. So like they're breathing one breath every 6 or 7 minutes. That's weird. You shouldn't do a CPAP with that. You should resort to probably a BVM to help regulate that rate. And inability to sit up. They can't sit. That they're like either laying down, or like on a backboard. And hypotension and shock. So we want to be careful because CPAP by nature tends to lower blood pressure just a little bit. So we want to be careful if they're already in hypotension or if they are a shocky patient. So we don't want to put a CPAP on them. Contraindications: nausea and vomiting. They feel, I'm gonna throw up. I'm gonna, yeah, take the CPAP mask off because it's gonna be a mess, and they may end up aspirating those fluids that they throw up. Penetrating chest trauma. Definitely stay away from that, and that's not the time to use a CPAP. Shock. We talked about that. Upper GI bleed from a recent gastric surgery. So they feel that they've been vomiting blood and they're having trouble breathing. Don't put them on CPAP. This is a problem that's bigger than CPAP. And contraindication: preventing good mask seal. So if you don't have a good mask seal, in essence, for that to work, so you get people that have like a giant bushy beard, okay, or a facial deformity of some nature, or they have a stoma, okay. So those are not the people that you want to put CPAP on. That's a kind of a contraindication. Side effects: hypotension, going to lower blood pressure. Pneumothorax, then it may cause pneumothorax in the lungs. Increases risk of aspiration because that fluid not going to have anywhere to go, and dries the corneas. So explain the procedure of the CPAP and start with a low level CPAP. So when you talk to the patient, like, look, sir, we're going to be putting you on CPAP. This mask is going to force air into your lungs all the time. When you want to take a deep breath, just relax your throat and let the air fill up your lungs. When you want to exhale, exhale forcefully against the mask. Okay, let's try this. 1, 2, 3. Take a deep breath. And now forcefully exhale. Okay, good. Every time you want to take a deep breath, take another deep breath and exhale. Don't hyperventilate. Just take a deep breath when you feel that you need to, and let the flow of the air do the job in filling up your lungs. Okay. Explain what the device does to the patient. Reassess patient mental status and vital signs, dyspnea level frequently. So there's levels on the CPAP. There is 2.5, 5, 7.5, and 10, which means how much of flow is coming to the patient of oxygen. So if there's no relief, increase it until you get the relief. And I think in our we'll talk about our regional protocols when the time comes, but you need to worry about reading the material and passing the test. So this is one of the things. So if you put a patient on CPAP and the question says they're not feeling any relief, what do you do next? Okay, you got to be careful. Difference between next and most appropriate. So next, when a question says, what do you do next? Next is literally the next on the list of things you need to do. A, B, C, D, E, and you go through the list. Most appropriate, not necessarily the next. I'll give you an example. So asking, patient having difficulty in breathing, what do you do next? Next, which means I'm going to put them on oxygen. Okay? When they tell you, patient having difficulty in breathing with no relief of home remedies, okay, and they're using retractions and stuff like that, what is the most appropriate? And it gives you a choice of a nasal cannula or a back valve mask or like an oral airway and a CPAP. Then most appropriate, CPAP. Reassess patient and continue to pay attention to their pressures. They hate that thing, okay, even though that's causing them relief, but generally it's not the most comfortable thing to put the patient through. If the patient deteriorates, remove the CPAP and begin ventilation via back valve mask. So when patients start losing consciousness and passing out, take the back valve mask and remove the CPAP. Start bagging. So, chronic obstructive pulmonary disease, which is a broad classification of chronic lung disease, includes emphysema, chronic bronchitis, and black lung syndrome. A lot of people that worked in coal mines, they have a black lung syndrome from all the lack of ventilation in the coal mine, and it caused them all these issues. Overwhelming majority of the cases caused by cigarette smoking, and I'm not gonna pick on anybody, but smokers tend to have this issue more than others. Chronic bronchitis, which is the bronchial lining is inflamed. Okay, so the trachea separates into right and left main bronchus, and it separates into bronchial branches. When those inflame, it causes bronchitis. Okay, so the bronchi wall is getting thicker, thus making the inside diameter of the bronchial tube is smaller. Excess of mucus produced, cells in the bronchioles that may normally clear the way for mucus accumulation are unable to do so. So here's the picture. You have what a normal, okay, uh, bronchial alveolar combination here, this junction, and you can see it's all clean shaved and ready to go to work, and this is what it does. So here is where you see the chronic bronchitis, the inflammation in these walls that preventing the air from getting in here and getting perfused and getting back out. That's where you develop a lot of fluids. Emphysema. See these little walls in between each alveolar sac have dissolved and went away. Okay, so those are lined with the same material of the alveolar wall. This is the alveolar wall. As you can see, you lost some of that capability to perfuse more oxygen. So that's what emphysema means. And we just talked about emphysema. Asthma, which is it's a chronic disease. I feel bad for a lot of people who are asthmatic. There's nothing they can do about it. This is something they're gonna have to live with. Doesn't just go away. During an attack, small bronchioles narrow, and sometimes they get into status asthmaticus, which means it's a rapidly evolving situation of asthma. Um, Excuse me for 1 second. Okay. So results of an airway passage that's severely restricting airflow. So airflow mainly restricted in one direction. Inhalation seems to be most of the problem. Expanding lungs exert pull towards. Exhalations opposite occurs when the air becomes trapped in the lungs. So abnormal accumulation of fluids in the alveolar system, that's when it comes to pulmonary edema. Remember, pulmon is lung, Latin word. Pulmonary is lung related. Edema is fluid collection. Abnormal accumulation of fluids in the alveoli. A patient with congestive heart failure, CHF, it's a very common problem that they would have that congestive heart failure. So the right side of the heart pulls the blood in. When it becomes congested, it will have trouble pulling adequate amounts of blood. What happens to that blood? It sits in the vessels, okay, in the lungs and in the abdomen, in the legs, and causes pedal edema, abdominal edema, which causes ascites, okay, which means their stomach fills up, balloons up with fluid, and pulmonary edema. Pedal edema, ascites, and pulmonary edema are the end stages of congestive heart failure, because pedal edema, ascites is a right-sided heart failure, lung and pulmonary edema is a left-sided heart failure. That means blood not getting evacuated fast enough out of the lungs and is sitting in the lungs and losing all the fluid content into the lung sacs. So pressure builds up in the pulmonary capillaries. So high blood pressure causes. So it's one thing cascading into another. If you don't take care of your health, one of these things gonna lead the rest of the chain reaction into these pulmonary high blood pressure cardiac issues. Kind of they circulate and revolve around each other. So what happens when a blood pressure increases is going to increase not just in your vessels where you're measuring blood pressure on the arm, it's going to increase everywhere in your ocular arteries and veins, in your cerebral veins and arteries, everywhere, wherever you have blood going, pressure going to increase. One of those places are the lungs. Blood pressure increases in that, going to force juice out, fluid out of the blood and into the alveolar sac. It's going to escape the path of least resistance. Okay. Fluid cross within thin barrier accumulate in the alveoli. We talked about that because of the semi-permeable membranes. And fluid occupying lower airways makes it difficulty to breathe. So you take the lung capacity and cut it in half, basically, depending on how much fluid is in there. So the common signs is the dyspnea, anxiety, pale and sweaty skin, tachycardia, hypertension. Normally you see those people with high blood pressure. I'm not talking about 130 over 90. I'm talking about like maybe 150 and above. Most of the time that we've been seeing it, 180, 190 or above 200 systolic over normal or high diastolic. So respirations are rapid because they're taking half of the volume that's enabling them to breathe. So they're breathing more to compensate for that. So low oxygen saturation, simply because the lung is not perfusing enough oxygenated blood. That's why it's happening. In a severe cases, crackles or sometimes wheezes may be audible. You kind of heard it in almost every patient unless the patient's level of pulmonary edema is so high. They are full of fluid, almost foaming out of the mouth. Okay, pink frothy sputum. They're trying to spit it out. That means there's so much fluid building up in the lungs. Patient may cough up frothy sputum. Yeah, look at that. And sometimes it's pink with a pink tinge to it. So treatment. Assess, treat adequate breathing. So first thing we need to fix is the mechanism. Look, you got a patient with SpO2 of 80 or 85%. You slap a non-rebreather on the patient, and now they're at 98%. Did you fix the problem, or did you just fix the number? Okay, we're not. It's like having a moldy wall, and you end up throwing a coat of paint on the wall. Did the mold go away, or did you just make it difficult to see? All right. So we need to think about the root of the problem that we're trying to fix with the patient. Okay, not just fixing the number that did not remove the problem that's causing that. So we need to think through the steps. A non-rebreather is not a fix. A non-rebreather is an assistant tool. It's not an ultimate tool. It's not the fix-it thing. It's one of the things that you need to fix. It's a tool in the toolbox. You're going to use it, but it's not the tool that you're going to be using for everything to fix the problem. So high concentration of oxygen if possible. Keep the patient's legs in, dependent on the position. CPAP may be used to push fluids back out of the lungs and into the capillaries. This is an essential step. You want to clear that lung, you have no way of suctioning all that fluid out. And you have no Lasix or diuretics that you can give to the patient. Even if you give it to the patient, it's going to take minimum of 20 minutes to get that fluid out. But you put a CPAP on, this is going to do it for you mechanically. It's going to clear out the lungs mechanically for you. So it does have a massive benefit. So it might be possible for the patient to have multiple respiratory disorders. So they could be asthmatic with emphysema and COPD and CHF. They could have all of that. On top of that, they could be a former lung cancer patient or lung cancer survivor, and they have lost a lobe or two out of the lungs via lobectomy. So they could be also breathing. You get to this patient that had a lobectomy and they're only breathing out of their left lung, and their SpO2 says 80%. Should that say 100%? They only have one lung. So by nature, SpO2 gonna drop. The patient gonna compensate for that. The body does amazing things. So could the patient be with an underlying diagnosed undiagnosed COPD, and it may have a pulmonary edema. So it could be a combination of two items that are going to make your job a little bit more difficult. So infection in one or both lungs results from inhalation of certain microbes. Hey, look, coronavirus time. Microbes grow in the lungs, can cause inflammation. Hey, look, corona freeze, the way to be. So, signs and symptoms: shortness of breath with pneumonia. So, signs of symptoms: shortness of breath with or without exertion, coughing is also a symptom, fever, severe chills, because think about it, it's an infection, so it's going to raise your temperature. And chest pain, often sharp and pleuritic. Pleura is the pleura tissue, okay, that's covering the lung. So, other signs and symptoms: you may have headache, pale, sweaty skin, fatigue, confusion. Excuse me 1 second. Sorry about that. So, treatment. Care mostly supportive. You're not going to be able to remove pneumonia in the field. It's going to take antibiotics and days of treatment. Assess and treat adequate breathing. If they need oxygen, put them on oxygen. And transport. That's how you treat pneumonia. Fever, breathing problem, may have a productive cough, may not have productive cough. Uh, Check their vitals, put them on oxygen if their numbers are below normal, or if they continue to, like, I can't breathe. So you need to fix that. So at least you did something about it. So spontaneous pneumothorax. So this is one of these mechanical problems that affects the lung function, and it's going to cause a serious, deadly, if it remains untreated. So lung collapse without injury or other obvious causes. So tall, thin people and smokers are at high risk. They pop a lung jumping from one level into another, or lifting something heavy, or just normal day function. You can never tell. It's almost like a tire blowout. But those people are susceptible to it when they're tall and thin, to spontaneous pneumothorax, which means lung perforated. So, signs and symptoms: sharp pleuritic chest pain. They feel this, like having trouble breathing, like could be on either side. They point at their chest, like, it hurts, like every time I breathe. Um, Decrease absent lung sound. So you listen to it, and I've had this with one of the patients before, where the right lung sounded like this. Oh, I'm gonna sound closer to the mic, like, and left lung was like you can barely hear it, air moving, and they're complaining of pain on that side that's missing those lung sounds, or diminished lung sounds. Shortness of breath, dyspnea, and exertion. Low oxygen saturation, that's a definite thing. Cyanosis, tachycardia. Treatment: transport to definitive care. So, as the patient frequently require chest tube, so you need to take them not to urgent care. You need to take them to a facility that can do that. Luckily, our local facility here in this area, Western New York, most of them can put in a chest tube, um, but you have to take them to a facility that can do that. Administer oxygen, and CPAP is contraindicated. Why? Because you are forcing pressure into somebody's chest. Okay? So with a lung that have a hole in it, you're filling up the exterior of that lung, between the lung and the ribs. You're filling that up with air. So that's ultimately going to cause that lung to collapse and fail and deflate on you, and going to put the patient in a worse shape than what you started with. Uh, Pulmonary embolism. So, look, this is one of these, like, almost instant killers, all right, with a pulmonary embolism. So, blockage in the blood supply to the lung. So, the heart pumps the blood into the lung to get oxygenated. Then you go ahead and throw a clot in there. How are you going to fix that without a surgery? So, commonly caused by deep vein thrombosis or DVT. One of the veins have a thrombus, which is a clot. We all have them. They circulate in our system all day long, and that's why some people are on blood thinners or antiplatelets or things of that nature to keep the blood from sticking to itself and forming a clot. But those people, unlucky ones, they get a pulmonary embolism. A blood clot peels off the vein wall and travels upstream, and boom, just blocked your circulation to portion or to the entire lung. So increased risk of uh, from limb immobility. So when people have a leg surgery or an arm surgery, those are the people that are at risk of having pulmonary embolus afterwards. So that's why they put those air cushions that pumps your legs at the hospital. The reason is moving the blood around and squishing your veins and muscles to prevent um, pulmonary embolism. It's recommended. There is some science behind it, but an actual benefit, the actual uh, source to eliminate that risk is to actually move the muscle itself. That's when they tell you when you fly for a long time, keep doing leg exercises in your seat because you could have a risk of embolism, especially when changing from high to low pressures. So signs and symptoms. Oops, way too fast. Sharp, pleuritic, chest pain, shortness of breath, anxiety, coughing, sweaty skin, uh, pale or cyanosis, tachycardia, tachypnea, which means breathing too fast, and wheezing. And treatment. Uh, Difficult and to differentiate in the field. Like, you can't diagnose pulmonary embolism. You show up, you may think it is, but you have no definite way to know that it's a pulmonary embolism. Transport to definitive care. Hurry up and get going, and give this patient as much oxygen as you can give them. So epiglottitis, we talked about that, which is an infection in the epiglottis, which is the leaflet-like structure that covers the trachea. Um, Signs and symptoms: sore throat, drooling, difficulty to breathing, swallowing. Mostly children get affected with epiglottitis. Preferred upright tripod position, sick appearance, and muffled voice. They're trying to talk because you got to think about it. The epiglottis is right above the vocal cords. So if that is inflamed, okay, they're going to have trouble getting sound out to talk. And stridor. You're going to hear that hoarseness in their voice every time they take a breath or they try to talk. Treatment: keep patient calm, comfortable. Don't inspect the throat. Don't agitate it because you may cause laryngeal spasms. The structure is already infected and you don't know how far that infection goes. So don't mess with it. Don't put a tongue depressor trying to look in the back. Don't do any of that. Okay. Um, Administer high concentration of oxygen if possible without alarming the patient. So don't go like, oh my God, here's an honor breather. No. Yeah, you need them like, all right, I'm just gonna try to help you with you. Like, talk to children, talk to them, like a small adult. Don't talk to them like a child. Don't use children words. Okay, you're a stranger. They don't warm up to you that quick. So just tell them, can I put this, Superman mask near your face or a Batman mask, whatever you want to call it, just to get these little guys to warm up to you, or give it to mom. Have mom put the mask near their face. Help them with this oxygen deficiency issue. And transport, definitely. So cystic fibrosis, again, that this is one of these things that we're going to end up dealing with in the field. It's a genetic disease typically appearing in childhood, causes thick, sticky mucus accumulating in the lungs and digestive system. Mucus can be life-threatening. Lung infection is serious. Um, so signs going to be coughing, fatigue, tired, frequent occurrences of pneumonia. They keep on getting it. Uh, Abdominal pain and distension. Their bellies are filling up because of they're trying to breathe and cough at the same time. Um, Coughing up blood. So this is a kind of a given. Nausea and loss of weight. So viral respiratory infections, infection in the respiratory tract, usually minor, but causes serious, but can be serious, especially if the patient is underlying respiratory disease or COPD. Um, so often starts with scratchy throat, fevers and chills. Infections can spread into the lungs, causing shortness of breath. Coughing can be persistent with viral respiratory issues. May produce yellow greenish sputum. So different color sputum is definitely a sign of infection. So pay attention to that. Yellow or green is a problem. So we're talking about a chronic pulmonary disease. So we're going to be clicking on that, and we're going to wait for this page to open, and we're going to move this over here so you can all see it.
Emphysema and chronic bronchitis are chronic obstructive pulmonary diseases, disorders mainly of middle-aged or older patients, in which tissues react to smoking, other pollutants, or
Can you
repeated
guys hear that?
infections. In chronic bronchitis, the bronchial lining is inflamed, excess mucus forms, and cells are unable to clear away accumulations because the cilia are damaged. In emphysema, the walls of the alveoli break down, reducing the surface area. The lungs lose elasticity, and stale air laden with carbon dioxide is trapped in the lungs.
Okay, there's that. Could you guys hear the volume on that video? Sweet. Moving on. Another video. Oh god.
A spontaneous pneumothorax often occurs as the result of the rupture of a subpleural pulmonary bleb. A bleb is an area of weakened lung tissue most often located in the apices of the lung that fills with air. As a bleb distends, its wall weakens and wall tension increases. Like an expanding balloon, the bleb will eventually rupture, creating a pneumothorax. Air then travels down the pressure gradient and enters the pleural space, and the lung collapses. The resultant ventilation perfusion mismatch and decreased tidal volume then lead to dyspnea and hypoxia.
So there's one more thing that they did not show in this video, which is I wish if they would just repair these instructional problems. Um, there's a divider between the right and left lungs called mediastinum that separates pressure of the right lung from left lung. So it's right here, but it doesn't show in this video for some reason. So back to the grind. The prescribed inhalers. Meter dose inhalers provides meter exact dosages for of inhaled medications. Most commonly used are prescribed condition causing bronchoconstriction. All right, so when the bronchus constrict and make it difficult to breathe, bronchodilators dilate the lungs. So basically, the patient most of the time are well trained and well versed in using it. So again, the right patient, right time, right medication, right dose, right route. Check for expirations. Shake the inhaler vigorously because some of the medication settles at the bottom, so there's no benefit of just giving them 10%. Patient alert enough to use the inhaler, and use the spacer device if the patient has one. So ensure the 5 rights of the patient when you administer any medicine. This is the spacer device that fills up this container with the exact dose that they end up inhaling, just this exact dose, to prevent them from over pumping or overdosing themselves with that medicine. So to administer the inhaler, have the patient exhale deeply, get all the air out, purse their lips right around the opening, and press the activated spray as the patient inhales deeply. So once you hit it, tell them, take a deep breath. So have them just inhale really deep, get this medicine to the bottom of the lungs. Not going to do any good spraying the back of their throat, but this medicine need to get to the bottom of the lowest, most distant alveoli. So as you can see, there's a picture of a nebulizer medicine via neb pipe as opposed to neb mask. Here is the inhaler spacer video. Okay, let's watch it, even though that kind of a mundane. Let me try this for a second. Let me see if this opens in a separate window. Click. Come on.
Administration of life-saving medications in the pre-hospital setting may be one of the most important things an EMT will do for their patient. It requires the ability to recognize life-threatening conditions, such as hypoglycemia or an asthma attack, knowledge of which medications are used to treat these conditions, and how those medications are administered. Some medications can be administered by the EMT, such as aspirin for chest pain and oral glucose for hypoglycemia, while other medications, such as nitroglycerin for chest pain, bronchodilators for difficulty breathing, and epinephrine for allergic reactions, must already be prescribed to the patient, and the EMT will only be assisting the patient with his or her own medications. A metered dose inhaler, or MDI, administers a prescribed dose of medication, usually to a patient with a history of chronic pulmonary disease, such as asthma or COPD, every time the inhaler is activated. The most common medications administered by this route are bronchodilators, which are drugs that dilate or relax the smaller air passages, making it easier to breathe. Because patients are becoming hypoxic during an acute respiratory emergency, they often will be agitated and unable to follow directions well. Therefore, you may be requested to coach or assist the patient in administration of their metered dose inhaler. Most bronchodilators begin to work immediately, and their effect can last for hours. The device through which these drugs are administered consists of a metal canister and a plastic container with an attached mouthpiece. The metal canister holds the medication and fits inside the plastic container. When depressed, the device delivers a metered, or an exactly measured dose of medication. The patient must coordinate their inhalation with activation of the device so that the drug will deposit itself into the bronchioles. Because the coordination can be difficult at times, some metered dose inhalers come with a chamber or spacer that attaches itself to the plastic container. The chamber holds the medication until the patient inhales it. Once you have determined that the patient is in respiratory distress as evidenced by shortness of breath, tachypnea, tachycardia, cyanosis, moist skins, accessory muscle use, presence of wheezing or silent lung sounds, and or is tripoding and has their prescribed MDI with them, follow these steps. Take BSI precautions. Explain the procedure to the patient and get his or her consent for an assist if needed. Keep in mind the 5 rights involved in administration of any medication. Ensure that you have the right patient, which is one in respiratory distress, the right drug, which is a bronchodilator, the right dose, which will be metered, the right route of administration, which will be inhaled, and right time, which is now, while the patient still has their own respiratory drive and can follow directions. Shake the canister vigorously for a few seconds. If the patient is wearing an oxygen mask, remove the mask. Instruct the patient to hold the inhaler upright in his or her mouth with the thumb on the bottom of the canister and the index finger on top. If the patient cannot do so, then you should hold the inhaler. Tell the patient to take a deep breath and to exhale fully. Have the patient quickly place his or her lips around the mouthpiece, making a tight seal. Direct the patient to take a deep breath slowly, over a 5-second period. Simultaneously, either you or the patient should depress the canister. Make sure the patient has started inhalation before the canister is depressed. Remove the inhaler and request that the patient hold his or her breath for 10 seconds or as long as possible. Coach the patient to exhale slowly with pursed lips. Replace the oxygen mask. The medications in MDIs usually cause an increase in heart rate, as well as a feeling of nervousness or shakiness. You may also hear more wheezing now that air is able to move through the bronchioles. Reassure your patient, but also be sure to document your findings.
That worked out. So small volume nebulizers are medications that normally run on oxygen or oxygen bottles that we carry with us. Uh, it turns the medicine that we give into nebulized format, so it's little tiny small particles that can reach the lungs instead of dumping fluid down the lungs. Patient may it's aerosolize basically. So patient may have an increase in coughing after you give them the nebulized medicine, and this is part of what it does. So make sure you assure them that you're gonna be okay. This is what it's supposed to do. So if you're coughing, something's happening, that the medicine is working. Chapter review, thank God. Do you guys want to take a break? You want to cast me a vote in the comments or in the live chat? Take like a 5-minute break. Before we get into cardiology, I need you fully functional. Okay, we got the votes for the break. Yes, let's take a break. Uh, let's make this just a tad little bit longer because I want you fully refreshed. Please don't leave because I'm standing over here trying to get you all caught up, and I'm really happy about that. And I'm glad that you guys are joining us in this experience. Hell with Corona is ain't gonna stop us from learning, and I'm trying to get you all caught up. So hopefully, when they open everything back up, you'll be all caught up on material, and you can take your test. And if you have any questions, definitely ask me. But please be back in front of your screens by 9 o'clock. We're gonna take a 10-minute break. Go grab something to eat, make yourself a cup of coffee, take your medicine, walk your dog. But please, by 9 o'clock, be right in front of the screen because we're going to carry on cardiology. And that will be the last lecture of the evening, and it's the most fun lecture. I think the respiratory and the pharmacology was kind of on the boring side, but this is going to be the way to go. So see you in about 10 minutes. I'm going to leave the stream wide open, please. Okay, we are back, and now we're gonna be cardiology. Oops. All right, are you all back? I'm waiting for the stream to get caught up.